Hi everyone. We're going to begin in just a moment, just giving people a couple of extra minutes to sign on. Okay, we're going to go ahead and begin. So welcome to Communicating Hope and Truth webinar. My name is Christine Benjamin, even though on your screen it might say Beth Kling is talking. My name is Christine Benjamin, and I'm the Breast Cancer Program Director at SHARE. So before the presentation begins, I'd like to tell you just a little bit about SHARE. SHARE is a 37-year-old nonprofit organization that helps people through breast or ovarian cancer, offering the unique support of survivors who've been there. Our services are free of charge and include helplines, support groups, educational programs, and public health initiatives. For more information, you can visit our website at sharecancersupport.org. So today's program will start with a presentation by Dr. Dizon, followed by Shirley Mertz, who's the president of the Metastatic Breast Cancer Network, and Ginny Knackmuhs, the Vice President of the Metastatic Breast Cancer Network. During the presentation, you're welcome to submit questions for any of the panelists. You can submit questions or comments through the question pane in your control panel. You can access the question pane by clicking on the red arrow in the upper right-hand corner of your screen. Type your question into the space provided, and you can raise your hand if you want by clicking on the hand icon, which is also in your control panel. Questions will be compiled and asked at the end of the presentation. So I'd like to introduce our first speaker, Dr. Dizon. Dr. Dizon is board certified in medical oncology and specializes in the care of women with breast and gynecologic cancers. Currently, he's an associate professor at the Warren Alpert Medical School of Brown University and sees patients in the Gillette Center for Gynecologic Cancer at the Massachusetts General Hospital Cancer Center, where he's also the founder and director of the Oncology Sexual Health Clinic. In addition to his role at MGH, he also serves as a deputy editor in oncology and palliative care at Up to Date. He's the editor of the annual meeting education book for the American Society of Clinical Oncology, ASCO, and is a member of ASCO's Communications Committee. He also serves on committees for the Society of Gynecologic Oncology, SGO, and the National Consortium of Breast Centers, NCBC. He publishes widely and speaks nationally and internationally on gynecologic and breast cancer, sexual health, and cancer survivorship. He's an active columnist for ASCO Connection at www.connection.asco.org, which was recognized with an award for publishing excellence in a 2013 Grand Award. We're so happy to have Dr. Dizon with us today. Thank you, Dr. Dizon.
Thank you. I'm so happy to be here. Are my slides now live?
Yes.
Okay, great. So I've been asked to speak about communicating cancer, delivering both messages of hope and truth. And as was already disclosed, I am a deputy editor at Up to Date on both oncology, which includes cancer survivorship, as well as palliative care. And the objectives of this talk are going to be to better understand how the way we communicate oncology often implies dual meanings, and this goes into areas of risk diagnosis as well as in the ways we impart language on treatment. And the main message of that is going to be to heighten awareness of the power of how we communicate, and then use that as a springboard to discuss ways to incorporate more sensitivity into communications, not only with our patients, but also with our providers and also with families. In terms of a perspective, I'll start with some cancer epidemiology, and then I'm hoping to impart on the why of how come I believe communication is important, particularly for women facing a diagnosis of cancer, and as well as for those living with cancer, and then suggest methods to improve communication while at all times retaining hope. So in terms of the epidemiology of cancer, there's nearly 2 million cases diagnosed each year, and almost 600,000 will die of malignancies. In fact, in the United States, it's 1 in 4 deaths are from cancer. And as we are aware, there is a disparity by race in terms of malignancies, and blacks, African Americans are at an increased risk compared to whites. What this also imparts, though, is a message of hope that with each successive year, treatments are getting better, detection is getting better, and as a result, cancer survivors are increasing. And within the United States alone, there are over 14 million who have at one point in their lives been diagnosed or are living with cancer. This sort of goes into the message of why the how we communicate matters. And the way I sort of got into this question and this area of interest was rather fortuitous. This is my column on ASCO Connection. And on one tumor board where we were discussing new patients, one of my earliest patients came to mind when the patient under discussion at that tumor board was quoted to me as, well, since she has failed her primary therapy, we need to go into a second line of treatment. And it got me thinking about a patient, and the first time I used those words in a clinical setting where I looked at a woman who had just progressed on her prior line of therapy and used that exact same wording. Well, since you failed treatment, we're going to move on to this regimen. And as I write in this blog post called The Power of Words, she looked away from me and started to sort of cry. And when she looked back, she told me that she was so sorry that I had disappointed her and that she had failed therapy because she never meant to fail anything. And I realized at that moment that the way I was communicating a message was actually broken. And instead of providing someone with hope, I was actually taking it away and imparting guilt. And I think that is a lesson that I've taken with me throughout my career. And it only came up again when I heard those words in a very new setting with a brand new fellow and realized we really need to sort of change the culture because it matters to our patients. This is a quote that came to me from that blog that I wrote, and it was someone living with metastatic breast cancer, and she talks about how when she was first diagnosed, her doctor had talked about restaging, and since she had just been diagnosed with metastatic breast cancer, she felt restaging sounded hopeful, as if perhaps the earlier oncologist and radiologist had been wrong, and maybe I did not, after all, have stage 4 cancer. Live and learn, because restaging does not mean I think we got it wrong. It just means we want to look to see how extensive that disease is, but that message was not imparted well. There are other examples, though, where communication becomes very important. If you think about women who are coming to you with metastatic disease, as well as those women who are coming to you with a new diagnosis, they are faced with a message that is quite predominant in popular culture, but also in the month of October, which was Breast Cancer Awareness Month. It was this notion that screening saves lives. It is a common thing we say, but we always need to define our audience because perspectives on this are not universally positive. And I will say it's especially true, particularly for those women who have been diagnosed with breast cancer, because screening equals early detection, but it does not mean prevention, and it certainly does not mean a cure. To cure breast cancer means to take women living with that disease and render them NED. That is not the population where screening for breast cancer matters anymore. In fact, someone else had commented, early detection of breast cancer is not the answer. Finding and treating all stage 0 breast cancers will not prevent all breast cancer deaths. Again, it's the metaphors are being mixed between screening for breast cancer, preventing breast cancer, and curing breast cancer. They're very different terms and very different concepts. For women who are living with or faced after the diagnosis, there's this concept of cancer as a war. It dates back all the way to John Donne, where illness was seen as a cannon shot or a siege that blows up the heart. And in 1864, the germ theory for infectious diseases gave way to infections as an invasion. But it was in the 1970s where Richard Nixon publicly declared the war on cancer, and cancer was depicted as the relentless and insidious enemy. But the war on cancer is problematic for some, not for everybody, but for some. War implies a battle, and battles are won or lost. So what does that make patients, soldiers? And what role does that give physicians? Are we supposed to be the generals? Are mammograms supposed to be the guards? Are chemotherapy supposed to be weapons? And when someone succumbs to their cancer, is that a defeat? Is death a defeat? And we do see that often, more often than probably we ever want to, where, she lost her battle to cancer. That's something that a lot of folks within oncology and those living with cancer really sort of start bristling with, and it's something that I've become more aware of. There's a war on cancer too. How many fronts can we possibly hold? These are some tweets that came about cancer as battle. It seems grossly unhelpful to the process of acceptance. If you're in a fight, you win or lose. Beyond just the war on cancer, it's how we talk about risk factors. So this is from Sex and the City, and it was around the time where one of the characters who's depicted here, Samantha, was diagnosed with breast cancer, and it's a very common clinical scenario. I don't understand how this happened to me, she says to her doctor. Well, some studies have shown women who haven't had children have an increased chance of breast cancer. Her response, I see, so I brought this on myself. Give me my chart. I'm going to find some woman doctor who understands what this is all about. I just meant statistically, you're lucky to have touched my breasts. Again, the whole notion of risk factors, obesity is a risk factor. Remember, the person we are talking to about these risk factors may have already been diagnosed with this cancer. There's very little to be gained by rehashing, how did I get this? They may want that information, they may want that reason, but we need to try to answer those questions without imparting blame. Because when words are meant to be reassuring, sometimes that dual meaning comes into play, and it's not that reassuring. Consider, well, at least you caught it early. What does that exactly mean? Does it mean early stage automatically means an excellent prognosis? Does it mean if you're early stage disease, you don't need to worry? Does it mean at least you caught it early, which means you won't need medical therapy or radiation? Or does it mean early stage, well, at least it won't kill you? This comment dismisses the fact I've been dealing with cancer for months. Tests, scans, appointments, procedures, surgery, missing work, more tests, more scans, more procedures, chemotherapy, radiation, follow-up. Then there's always the wondering about a recurrence. At least they caught it early. End of story. Pass the salt and pepper. Again, these words can be very powerful and loaded, particularly for this person who's been diagnosed with cancer. When we talk about treatment, there's a whole host of other communication pitfalls that can be misinterpreted. Treatment is never a benefit, and probably breast reconstruction is one of the biggest areas where this comes out. Because types of breast surgery, mastectomy versus wide local excisions, these are difficult decisions for patients to make after the diagnosis of breast cancer. And breast reconstruction is never seen as a benefit. When can tell my oncologist? Well, you will have perky boobs at 85. At least she thinks I'll live to 85. Well, at 49, I had beautiful perky boobs that I could feel, and nipples I could feel. At least you get perky new boobs. Honey, you have clearly never seen reconstructed breasts. Trust me, nobody is giving me any beads during Mardi Gras. And then finally, minimizing of side effects really doesn't help. So when I talk about chemotherapy, I actually put in a lot of stock and investment in talking about alopecia or hair loss and how that can be a traumatic side effect for men as well as for women. So it's not a gender-specific event. So to say you'll look fine even without hair, if it's you or if it's someone you love saying it to a patient, that actually is a trivializing event that probably is unnecessary, because over 50% of women getting chemotherapy will experience this as a traumatic thing. Rarely, and this is also important because we always say, you know, your hair will fall out, but it will come back. Realize that persistent alopecia does happen, although rarely, and, you know, incidence is all over the place, but 3% among those women treated with docetaxel is just one figure. This is from the Globe and Mail from a patient who had permanent alopecia from chemotherapy. It's devastating. With no hair, there's no going back to normal. Then this is the final thing. You know, we think of end of chemotherapy, and I think it happens with patients and their families, patients and their friends, patients and their infusion nurses, as well as their doctors. At that last chemotherapy, that last treatment, we want to throw a party. Go off and live your life. You're finally done. But that really de-emphasizes how hard that can possibly be. Achieving a new normal is not an automatic event. It is actually a process that happens with time. And at the end of treatment, it's the heightened part where women are afraid, men as well, of recurring. And that can last from the first 6 months after treatment all the way out to a year, even more. It's a time of increased anxiety where every symptom can raise a specter of, oh, geez, what is this? Is this a recurrence? The expectations are unclear. What it means to be outside of treatment is unclear, primarily because they are not who they were before they got cancer. All survivors, though, will require follow-up. So it begs the question, when we say go off and live your life, do we mean it? Is the cancer experience really ever over? So how can we do better? And this is an important question in oncology because it's an extreme model for medicine. The disease is unpredictable. The diagnosis itself is met with dire prognoses, true or not true. But there's also no guarantees on what that future may hold. Realize that we as clinicians, physicians and nurses and advanced care providers, as well as the patients, we all experience the anxiety of that cancer diagnosis, uncertainty, and yes, there is even some distress. Because the facts about most cancers is that not everyone is curable. We may know what prognostic factors there are, but they vary by cancer. For newly diagnosed patients with non-metastatic or non-advanced disease, usually we say that there's one chance for cure, and that's adjuvant treatment. But these treatments are toxic, and they can lead to changes that last beyond the end of therapy. And we are all hearing about precision or personalized medicine, the roles of biologically driven therapies. Realize biologic therapy does not necessarily translate into less toxic therapies. And again, the side effects may or may not end with treatment. So what we say is important, but realize the time we say it is also important. So for the newly diagnosed person, we may talk about the biology or the science of cancer being heterogeneous. Molecular profiling shows that there's really no one type of breast cancer, but there's multiple types. We may talk about the natural history of how it spreads through the bloodstream, lymphatics, or locally. And we may talk about treatments and options and how these vary. But realize at the point of diagnosis, with that first conversation, it may not be what she hears. She may hear, this is bad. She may feel, I think I might die of this. Natural history, she may hear, oh, this is really bad. And she may feel, oh my God, I'm going to die. And treatment options. These all sound bad. And she may feel, either I'm going to die of cancer or these treatments will kill me. So the bottom line here is that patients do want information. but they want to be able to understand that information. So we need to engage them cognitively, which means talking in their language, at their pace, at their level, so that they can understand, even if it means returning for a visit and redoing that conversation. Patients also do not want to lose hope, so we need to read their body language. We need to look into someone's eyes as opposed to the pieces of paper on our desks. We need to engage them effectively. So how can we do better? At the ASCO annual meeting this year, we talked about a communication toolkit, acknowledging emotion being incredibly important. And during that initial visit, using plain language, not assuming prior knowledge. So going in and say, so you're aware you have stage 3 breast cancer. That's not a great way to start out a conversation. Addressing the elephants in the room, and then giving info in bite-sized chunks, not spewing it out for 45 minutes and expecting that 45 minutes to be time well spent, and then asking for a teachback. So I'm going to go through some of these in a little bit more detail. But the way we approach decisions has to be shared. So what does that mean? It means for any option that's on the table, it means taking the time to define both the benefits as well as the risks, and realizing that these benefits and risks only matter based on what your patient is viewing that from. So again, it's this evidence-based approach that builds off of values as well as preferences. It encourages the participation of others. And again, it's an invitation to participate in care. And it's the recognition that sometimes some patients will not hear everything that they need to hear, so we may need to repeat it, and that's okay. So the acknowledgement of emotions is not something that happens readily. This is one study out of Duke of almost 400 visits. They recorded these visits. They went back and they categorized every visit, and they looked for emotional instances of emotion that were acknowledged. These research identified almost 300 opportunities where a physician could have reacted to a patient being emotional. The response was recorded less than a third of the time. It matters, though, because patients do want honesty and accuracy, but they will read both of these better if the information is transmitted empathically and with understanding. And because the acknowledgement of these emotions enables a patient to hear more, and at least some data show it enables the retention of information or education. These are incredibly important things, particularly when someone is thinking about treatment for cancer. Regarding treatment, using plain language is important. Basically, using the most basic of statistics, and again, both benefits and risks being explained. In terms of these benefits, statistics that give absolute percentages versus relative percentages are important because it allows someone to actually wrap their hands around a number. And using graphics seems to make a better sense to the patient of how to interpret what we are trying to tell them. But again, to only present benefits and not touch on risks is just to give half of that picture. We need to give them both because both will inform preferences. And this is something that came out of MedX this year, and I think it tells the story all at once. Evidence-based guidelines, all the evidence in the world, these are not mandates. They need to be interpreted by the preferences and the values and the goals of the patient who's hearing that evidence. In terms of how do you approach the future after a diagnosis of cancer, offer to discuss it. It does not mean that we automatically will discuss it, but allow her to tell us where to go next. How much have you been worrying about the future? Sometimes people are a bit hesitant to ask about what to expect, or what information about the future could help you be prepared. And then finally, asking for a teachback. So spewing a lot of information is one thing. Trying to get a sense of what information stuck is another thing. Tell me what you're going to tell your best friend about this. It will help me know if I've been clear, or what are you taking away from this part of our discussion? And then finally, praise, because praise can be a very positive reinforcement. It's an appreciation of the work it takes to come to your visit, to attempt to listen to everything you're saying. And it allows you to build a relationship. It's working on understanding, and it's consideration of others. So in summary, you want to address the elephant in the room first, but you want to do it in a way that is sensitive. So is the disease terminal? Can I die of this? Can medicine help? Do they offer any guarantees? Most patients who come in to see me with advanced breast or ovarian cancer, for example, have these questions in their mind. They may not want to state it, but usually I can look in their eyes and I can see that fear. Trust is critical. So in general, I usually will say at some point in that initial conversation, if I think I cannot help anymore, if I feel you are dying, I will be the one to tell you it's time. I'm not telling her it's time right now. I'm not telling her she's dying right now. I'm not even saying I cannot help you right now. But I am setting up a time to say, if it happens, you will hear it from me. So in conclusion, words have consequences, and it can be when we're talking about anyone who's worried about cancer. It can be after the diagnosis of cancer. It can be when we're talking about treatments of cancer, and when we're talking about prognosis. There are consequences to how we communicate. So speak plainly and clearly, and realize that metaphors can both help and confuse. So think before you speak. That's how my mom had taught me that. Acknowledge concerns and fears. Address the worst case scenario, and never trivialize the experience. Because cancer is an incredibly scary process, but we can help it make it less so. And with that, I'll close. Thank you very much.
Thank you, Dr. Dizon. So now we're going to hear from Shirley Mertz and Ginny Knackmuhs. Let me give you a little bit of a bio on both. So Ginny is the current Vice President of the Metastatic Breast Cancer Network. She was diagnosed with stage 4 in April 2009 with a previous history of DCIS 17 years earlier. She began volunteering with MBCN in 2010 and worked on launching the new MBCN website in December of that year. Before becoming an advocate, she had a career in IT for the health information and pharmaceutical industries. Shirley Mertz received a metastatic breast cancer diagnosis in 2003 after treatment for early-stage disease 12 years earlier. After completing Project Lead and Clinical Trials Lead, she became a research and policy advocate on behalf of those living with metastatic disease. She's the president of the Metastatic Breast Cancer Network, which seeks to educate and empower those living with the disease. She's a reviewer for the DoD Breast Cancer Research Program and an advocate in science for Susan G. Komen. She serves on the Translational Breast Cancer Research Program as the advocate representing the University of Chicago and is a board member of the National Breast Cancer Coalition. Shirley is married and has 2 adult sons. So I'm going to change over the screen here to Ginny. And we should see Ginny's slides in just a minute. There we go, Ginny, I can see your slides. Yeah.
Good.
Okay, Shirley, you're unmuted and you're free to talk.
Thank you, Christine. The Metastatic Breast Cancer Network is pleased to partner with Dr. Dizon and Cher to offer this webinar to healthcare professionals, and we know there are patients listening in. Our comments are based on our own experiences with the disease, surveys that have been done of metastatic patients, and the many patients we have met over the years at our annual conferences. The first slide speaks to the goals of treatment. As Dr. Dizon has said so artfully, communication between doctor and patient is challenging for both. It is important for healthcare professionals, we believe, to understand that newly diagnosed metastatic breast cancer patients will be in shock to hear that their disease is incurable. An important follow-up to share with that news of the disease being incurable is to share with patients the goals of metastatic treatment, that of controlling the disease while maintaining the patient's quality of life. And for each of those terms, disease control, quality of life, those need to be explained and defined. Certainly those two words will have some nuances depending on the bulk of the disease, location of the disease, and whether organs are involved. In addition, sometimes terms are entirely new to patients, as well they might be if they've never had metastatic breast cancer. So a term like stable disease is something that needs to be explained, and why it is in many instances good and welcomed. Another term that patients often know about is NED, no evidence of disease on a scan. Patients often refer to this as dancing with NED, and yet we need to explain to patients that while they are not cured of disease, this is a wonderful outcome of treatment. The elephant in the patient-doctor room will always be the question, how long do I have to live? And Dr. Dizon touched on this previously. I would hope that healthcare professionals would respond that no doctor can exactly predict the survival rate or the survival number of years an individual patient will live. And while many patients will turn to statistics on the internet, I think it's important for doctors of patients to say that those statistics are median years of survival and explain to them what the word median means. I like to tell patients when they talk to me that each one of us is a statistic of one. So even those who present with extensive mets, if there is a treatment or treatments to target that patient's specific tumors, the outcome can be good even in that situation. Okay, next slide. The idea here about acknowledging the whole person is that a compassionate doctor treats the whole person who is more than their cancer. When a doctor walks into the room, we would hope that they would not immediately begin to discuss their tumor results or scan results, but instead would acknowledge the patient as a person and their emotions of the moment. By getting to know your patients early on and what is important to them, we believe that this information can be used by the healthcare professional to explain how a treatment that the doctor is suggesting could impact their work, the patient's work, hobbies, or family life. And now, Ginny, we'll go on from here.
Yes, hi. This next slide is about information. We recommend that, especially on the first visit, when you're discussing what the diagnosis means, that every patient should leave that doctor's office with something in their hand, a pamphlet or brochure, that will be a guide for them on, what it means to be newly diagnosed. And, as we've already mentioned, it's very traumatic to hear you have breast cancer, especially metastatic breast cancer. So your mind is racing and you're trying to take it all in. And believe me, when you get home, you have a little chance to sit and think about it, and you really want to then, sit down and read something and reinforce, hopefully, what the doctor has said. So I'll give a little commercial here. We do have a guide that we produced with between Metastatic Breast Cancer Network and another breast cancer organization, Living Beyond Breast Cancer. And that is available free of charge on our website and on LBBC's website. But there are many good publications out there. I think every pharma company has one, and many of the health information magazines have things that are very good, metastatic issues that would be nice to hand to a patient. The other thing, as time goes on, you will find that patients are going to ask you for recommendations. And of course, the internet is really where a lot of people get their information now. And so, they will ask you for recommendations of what are good sources of online information. And I think most doctors would, automatically go to think of cancer.gov, the NCI site, cancer.net, ASCO site, cancer.org, American Cancer Society. But there are also a number of other specific breast cancer sites that also deal exclusively with metastatic breast cancer or advanced breast cancer, or that have a particular section on their site. One of the problems with being metastatic is that you have to dig down, really drill down on a lot of sites, go through a lot about early stage, and then get to a small amount about metastatic. And so obviously we're not asking oncologists to be up to date on everything that's out there, but it might be something to think about. Someone on your staff that would be a good resource for this. If you use a hospital infusion center, certainly be able to recommend. The social workers usually are very good on this, and they're also aware of local programs and webinars by organizations. So that's just something that's really important, and something that you want to keep in mind. I'm also always very glad to bring anything to my oncologist that I've read, any article or any story or any research, and he's able to put it in context for me. What's the source? What does this really mean? And how it would affect me? And that's something that's very, very helpful. Of course, the caveat here is that along with doing everything else, the oncologist also has to differentiate among their patients what the preference is of that patient really for the amount of information. Nowadays we have a lot more proactive population. People will get copies of their lab work, copies of the blood work, copies of their scans. And, a lot of people are on the internet a lot and participate in message boards and so on. But not everyone is like that. And, it's important as you develop a relationship with the patient, to try to sort out how much information is actually going to be helpful for that patient. This next slide is also just about practical matters, and this is something that is probably almost assumed, but it's important that it doesn't slip through the cracks. And again, maybe it's not the oncologist that's going to map this out for the patient, but particularly when you're a new patient, newly diagnosed, and you're trying to absorb your diagnosis and what this means, you may not have really listened carefully to what the specifics are. And the point of this is it does lessen anxiety and stress if you know who you're supposed to call, what number. Does the oncologist use email? When are the phone calls returned, and will it be from the oncologist, or is there a nurse practitioner? What should I expect in terms of waiting times for an appointment, and even interruptions during the visit. I know a lot of times patients really value their visit time with the oncologist, and a lot of times it's a busy day, and the oncologist is taking a lot of phone calls, and that makes you kind of feel like you're just being fit in here. Or is he really paying attention when he comes back, he or she comes back to talk to you? And just kind of explaining and apologizing to the patient that you have to take the call, or just explaining that it is difficult for doctors to play phone tag and get back and forth to each other. So I think that goes a long way to making the patient feel like, well, I'll pay it forward here at some point. Maybe I'll be the one whose call is interrupting somebody else's visit. So that does make a difference. And then, of course, test results, how those are communicated. How many days after you have the test? Is it going to be the nurse that calls? Is it the nurse just if it's good news? Otherwise, it's the doctor. Again, just kind of simple things here, but just knowing how things work is, is going to lessen the anxiety and I think help the patient and help your relationship with the patient.
We turn to another area of supportive services. While oncologists have been trained to understand the biology of early-stage breast cancer and also that of metastatic disease, treatment resistance, and how to select treatments for patients, surveys of metastatic breast cancer patients in the United States and even globally have shown that metastatic breast cancer patients also want, in addition to treatments from their physicians, they want their emotional and supportive needs met from their healthcare professionals. And 3 conditions that greatly impact the quality of life of patients are pain, anxiety, and the ability to sleep. And we believe that these conditions should be asked about each time a patient comes in for a medical visit or a treatment visit. Now, we certainly recognize that the time of the oncologist is limited, and I think most patients would say that they are not expecting the oncologist to become the psychologist or social worker, but we believe that the oncologist could create a system in their office where a particular person, perhaps a trained oncology nurse, could assist patients with their supportive needs, whether it be referrals to someone within the office or breast cancer center who could see them if they're feeling a great deal of anxiety or sleep issues or want other support from a support group. So we believe that treatment will be better for patients if these supportive services are offered, and they could impact the course of disease. Next slide. And this is kind of an interesting position that we've learned lately through some surveys of patients. Patients are always asked to let doctors or the nurse know about adverse effects or toxicities they may be experiencing, symptoms from a treatment that they are on. And I think oftentimes doctors will say, now be sure to tell us, but they might also accompany that statement with a statement that, for your type of disease, the treatment I'm going to give you has been shown to work really well. And so the patient begins with hope that this is the right treatment for their disease, and then they discover that they might have severe diarrhea or debilitating hand-foot syndrome as examples. And we have learned in surveys of patients that patients tell us that they then are oftentimes hesitant to mention these toxicities for fear that the healthcare professional will stop their treatment because of the symptoms. So what we're suggesting here is that the doctor explain early on to patients that when we know about these symptoms, we may decide to withhold your treatment for a short period of time or reduce dose or take some other action. And what we're doing is trying to avoid having to hospitalize you for symptoms from the treatment. And while we are talking about symptoms, in particular pain, we hope that healthcare professionals early on would explain and offer palliative care to patients and specifically state that palliative care is not the same as hospice or end-of-life care. And because certainly I think we would all agree as cancer patients that controlling pain enhances our quality of life.
Well, of course, the goal of communication is understanding, and just my first point here, I want to reiterate what Dr. Don had said, that you certainly want to confirm that the patient has understood what was said during the visit. You might, if the patient's by themselves, you might want to encourage them to bring someone with them, you know, just to offer another set of ears listening to things, especially if it seems to you that the patient is not getting it all. You also should suggest maybe that they could record the visit. With smartphones now, that's easy to do, and certainly to take notes. And it's nice if the oncologist is proactive about this, because again, people are sometimes a little bit hesitant to ask, can I record this, or take the initiative. We just wanted to mention on this slide two topics that are commonly misunderstood in our experience, and one is that is about tests, and there's a term that is used in the metastatic breast cancer community called scanxiety, which means anxiety over waiting for those for the scan and then waiting for the results. And I'm sure as oncologists, when you select a test to be done, that you obviously you go through what they should expect and what this test is going to measure. But what happens with a lot of patients also is they will talk to other people. They might be in a support group or on a message board, and they might say, gee, my cancer is exactly the same as so-and-so's, and yet I do CT and bone scans, and this other medical center just exclusively does PET. So, what's the difference, and am I really on the right monitoring tool? So it's important to include in that, in your discussion of tests, why you choose one over the other, and that just again the pros and cons. There's no perfect test, obviously, but I think kind of emphasizing that it would be very helpful for patients. And another area that's really tough is tumor markers, and I'm sure a lot of doctors would be happier if patients never got the reports on their tumor markers, because they are really misunderstood. Of course, they're just one part of the decision making. I don't think any oncologist just goes strictly by tumor markers on deciding on a treatment, but patients do get fixated on those numbers, and we just say that it's almost not enough that you can say about them in terms of putting them in context that they are just one test. They work for some people as a good indicator, but not for others, and that people really shouldn't get so upset about them before, before you really evaluate everything that comes into the picture. And our final slide is just on next steps. Of course, it's good to focus on the future and keep hope alive. One thing that my oncologist does that I really like is that even if I have a good report, no progressions, he's always mentioning certain drugs, that might be in my future. What's the next thing we might go to? And he'll also mention, a clinical trial or a research area that's, going to have an impact on me and that might, at some point enter into my treatment plan. And, what I think is really great about this is it sort of sets the expectations that in managing metastatic breast cancer, we know there's going to be progressions and that they're expected and that we're planning for them and that we're going to deal with them, that there are options. And so I think it does give the patient hope, and it gives them, for a patient that wants a lot of information, it gives them some ideas on what to look into to kind of, keep your ears open for information about a certain drug, because eventually maybe you would be on that. And I think if you do this kind of communication with the patient, that when there is a progression, it's easier because you've been expecting it. And then I think it also prepares the patient for eventual final decisions, because all along we've been saying we're going to, we have this, this, and this to do, and the patient's going to realize our options are getting fewer, and I think it makes an easy transition to say, well, at this point, our options are really limited, and do we really, want to look at this chemo, the toxicity, the, and see whether it's really worth doing. So that is our final slide, and in closing, I just want to, Shirley and I both want to thank Cher and Christine and for allowing us to participate. And I also wanted to say we really do want to thank all the oncologists and future oncologists, because you have to know that the patients in the metastatic community are really very, very grateful for your wisdom and your hard work and your dedication. And I hope that this seminar has given everyone some good ideas to think about so that we can strengthen that relationship, which is very, very special. Thank you.
Well, thank you to all the presenters. We have a couple of questions, about 5 minutes left. So let me get started with a question for Dr. Dizon. How do you feel about giving a patient their chart notes or allowing them to record a session so that the patient can listen to it later, listen to the questions that they've asked, and
Right. I think I've evolved in terms of the recording aspects. When I was in training in New York City, it was actually fairly frowned upon in terms of having someone record the conversations. And it wasn't necessarily because there was some fear that the information was going to go somewhere else. It was mostly it may prompt questions and we weren't there to answer them. So the notion about recording and why I was fairly uncomfortable doing it previously was because I wanted to be the one to explain as opposed to have someone play back what I said and become more confused as opposed to more clear. I have come around to that, and I do allow some folks to record if they wish, but I also stress my preference is that it not be recorded and that notes be taken, and that I will repeat whatever you need me to repeat as many times as you need me to do that. So knowing that, there is no time limit on my time, and, leaving that option open to revisit any issue, in fact, the entire discussion, if that's going to be helpful, is sometimes a very important message to bring out to folks. In terms of giving people their notes and allowing them to read it, I have absolutely no problem with that. Oftentimes, if patients are going to travel for vacations, I insist that they take my last note with them, which spares them having to rehash the entire medical history of cancer from the point of diagnosis, and I find that it's been incredibly helpful. I think the records we take should reflect the visits as they happened, and so hopefully there's nothing contained in any of our notes that would be a surprise to the patient themselves.
Great, and one more question for you, and then I have a question for Shirley and Ginny. So you hear that the reason that some doctors come across as uncaring or cold or have a poor bedside manner is because it's hard to be emotionally invested without becoming emotionally exhausted or burnt out. How do you deal with this?
Well, I think everybody has to find their place and their balance. I think neither myself nor Ginny nor Shirley can tell any physician what that balance needs to look like. There is an importance to self-preservation. I think a lot of it depends on who you are in terms of your own personality, because I do not think that one can change that. I would suggest, you know, if your personality is not one of adapting easily to, say, reaching out and hugging a patient at the end of a visit, then to force yourself to do that would come across as probably ungenuine. So finding your own balance is really important. Styles differ, just like personalities differ, just like patients differ. We should embrace who we are as people, and I think if we can do that, we can become better physicians.
Great, thank you. And Ginny or Shirley, either one of you or both can take this question. What's the best advice you could give to women living with metastatic breast cancer or advanced ovarian cancer?
I'll just share quickly, and Ginny could add. I would say information. Empower yourself, although it may be scary at first, with information about your disease so that you can be a true partner in decision making. Ginny?
Yes, I would agree with that 100%. And the other thing I would say is just to take a deep breath and remember on your initial diagnosis, you don't have to rush into anything. You do have that time to, you know, get a second opinion, to, you know, talk to your oncologist, to, you know, pick what your treatment is going to be. And because this is going to be a process, and the key is to have an oncology team that you are comfortable with and that is going to meet your needs, because you are going to be spending a lot of time together.
Right. Great, thank you. So thank you all for participating. Before we stop here, I just wanted to say, if you have a chance to see Dr. Dizon in person, please do so, because he's even better in person than he is on a webinar. And I don't think I mentioned it in his bio, but he recently spoke at ASCO, and I had the pleasure of seeing him at the MBCN conference in September. And he spoke there 2 or 3 times and was absolutely fantastic. And you can just tell.
Thank you for that.
You're welcome. And so if you ever have a chance to see him live, please do that. And I just want to thank Shirley and Ginny. I have so much respect for MBCN and the work that the two of you do. And for participants, if you're able to attend the MBCN conference, please do that. Check out their website, mbcn.org. And it's an annual conference in September or October. Do you know where it is next year?
Not yet.
Okay.
Not yet.
We will let you know.
Right, and the information will be on the website. So thank you all very much. Participants, if you wouldn't mind filling out an evaluation, that should come up as soon as I press the stop button here. That would be fantastic. Visit us at sharecancersupport.org, and we hope to see you again at the next webinar. Thank you all so much.
Thank you so much.
Thank you, Christine.
Okay, bye.
Thanks. Bye.